Hello everyone, welcome to Anima Anatomia. Today in this video, we will cover these topics. Sutures, temporomandibular joint, atlanto-occipital joint, atlanto-axial joint, costovertebral joint, intervertebral joint, sternocostal joint, sternoclavicular joint, mandibulosternal joint and xiphisternal joint. Let's start with the sutures. So sutures, these are the fibrous joints that connect the bones of skull, and these joints are fixed, immovable and have no cavity. These joints are also referred to as synarthrosis. In fetal skull, the sutures are wide and allow slight movement, but later they become rigid and fixed. In this diagram, you can see the difference between the adult skull and the infant skull. In adult skull, there are no gapings, whereas in the infant skull, there are gapings which are known as fontanelles. Now, according to the shape of bony margins, these sutures can be divided into plain, serrate, squamous, denticulate, and syndialysis. For the plain sutures, we have the example internasal suture. For the serrate suture, we have example interparietal suture. And for squamous, we have temporoparietal. Denticulate, we have lambdoid suture. And syndialysis, it is the suture between the rostrum of sphenoid and the upper border of the vomer. We can see the difference between these sutures. The plain suture, the articular surfaces are plain. For the serrate, these are the zigzag surfaces. And for the squamous, it is oblique. And for the denticulate, it is like a dentine. And for these syndialysis, we have the wedge and groove suture. Here you can see wedge and the groove. Now, on the anterior aspect of the skull, we have the frontonasal suture, which is present between the frontal bone and the nasal bone. Then we have frontozygomatic suture, that is present between the frontal bone and the zygomatic bone. Next, we have the zygomatico-maxillary suture, which is present between the zygomatic bone and the maxilla. Next, we have intermaxillary suture, which is present between two maxilla, and the metopic suture, which is found only in children as it is present on the midline of the frontal bone. Next, we have the posterior aspect of the skull. So, on the posterior aspect of the skull, we have the sagittal suture, which is present between the two parietal bones. We have the lambdoid suture, which is present between the parietal bone or the temporal bone and occipital bone. Next, we have the lambda. Lambda, it is not a suture, it is a point of the convergence of sagittal and the lambdoid suture. Now, for the superior aspect of the skull, we have the coronal suture, which is present between the frontal bone and the parietal bone. And next, we have bragma. Again, just like the lambda, bragma is a point of convergence of sagittal and the coronal sutures. Now, let's talk about the lateral aspect of the skull. For the lateral aspect of the skull, we have different sutures, like squamous suture, which is present between the parietal bone and the temporal bone. And then we have sphenofrontal suture, which is present between the frontal bone and the sphenoid bone. Next, we have sphenoparietal suture, present between sphenoid bone and parietal bone. Next, we have the occipitomastoid suture. It is present between the occipital bone and the mastoid process of the temporal bone. And last, we have the temporozygomatic suture, which is present between the temporal bone and the zygomatic bone. Now we talk about the inferior aspect of the skull. On the inferior aspect, we have the median palatine suture, which is present between the horizontal plate of the palatine bone. Next, we have the transverse palatine suture. It is present between the palatine process of maxilla and the palatine bone. Next, we have the petro-occipital suture, which is present between the occipital bone and the petrous part of the temporal bone. Next, we have the spheno-occipital suture. It is present between the sphenoid bone and the occipital bone. Next, we have the petro-squamous suture, which is present between the petrous and the squamous part of the temporal bone. And at last, we have the petrotympanic suture, which is present between the temporomandibular joint and the tympanic cavity. Now, moving forward, we will talk about temporomandibular joint, that is TMJ. It is a hinge type of synovial joint, and its main function is to facilitate movements of the lower jaw. In this diagram, you can see the temporomandibular joint, which is present between the temporal bone and the mandible. Now, we have different points about temporomandibular joint. We will read about articular surfaces, main components, ligaments, cavities, rotational movements, and the translational movements. Now, let's start with the articular surfaces. It is a joint formed between the mandible and the temporal bone. The superior part of joint is formed by two components, mandibular fossa and articular tubercle of the temporal bone, whereas the inferior part formed mainly by the head of mandible, which is known as the mandibular condyle. And between these two articular surfaces, there is a disc, which is called as articular disc of the temporomandibular joint. And what is the function of this disc? This disc stabilizes the condyle of mandible within the joint and reduces the friction between articular surfaces. In this diagram, you can see this is the head of the mandible. This is the mandibular fossa. So, it is a joint formed between these, and in between that, we have different things, like we have the fibrous capsule, and we have the intra-articular disc. This blue color, this is the intra-articular disc. Let's talk about the compartments. In temporomandibular joint, we have two compartments, superior compartment and inferior compartment. And each compartment is lined by its own corresponding synovial membrane. Now, let's talk about the superior compartment. Superior compartment is superiorly bounded by mandibular fossa of temporal bone, inferiorly by articular disc, and it is lined by superior synovial membrane. This compartment contains approx 1.2 milliliter of synovial fluid and responsible for the translational movements of joint. Later on, we will discuss about translational movements. Next, we have inferior compartment. So, inferior compartment superiorly bounded by the articular disc, inferiorly by the condyle of mandible, and it is lined by the inferior synovial membrane. And this compartment have average synovial fluid volume of 0.9 milliliter, and it allows the rotational movements of joint. Now, moving forward, we will talk about the ligaments and the joint capsule of temporomandibular joint. The joint capsule originates from border of the mandibular fossa and it encloses articular tubercle of temporal bone and inserts at the neck of the mandible above pterygoid fovea. And we have two types of ligaments in temporomandibular joint, the intrinsic ligaments and the extrinsic ligaments. The intrinsic ligaments, we have the lateral ligament which strengthens the joint laterally, and extrinsic ligament, we have the stylomandibular ligament and sphenomandibular ligament. The stylomandibular ligament, it runs from the styloid process to the angle of mandible. As per the name, you can identify from where the ligament runs. Stylo means styloid process and mandibular means angle of the mandible. And then we have the sphenomandibular ligament. This sphenomandibular ligament runs from the spine of the sphenoid bone to the lingula of the median aspect of ramus of mandible. In this diagram, you can see the fibrous capsule. Here it is located. Then we have the lateral or temporomandibular ligament. This one. Then we have the sphenomandibular ligament, which is present internally. Here you can see it's come from the sphenoid bone, spine of sphenoid bone to the lingula of the mandible. Then we have the stylomandibular ligament. It runs from the styloid process to the angle of mandible. Now moving forward, we will talk about the movements. So these movements are divided into two parts: the movements which are done by the superior compartment and the movements which are done by the inferior compartment. Basically, there are three movements which are done by the superior compartment. These are protrusion, retraction, and left and right lateral division. In this, we will also discuss which muscles are involved in the which movement. First, we will talk about the protrusion. Protrusion, that is the anterior movement of mandible. The muscles which helps in this movements are lateral and medial pterygoid muscle. Next, we have retraction, that is the posterior movement of mandible. The muscles involved are posterior fibers of temporalis, deep part of masseter muscle, geniohyoid, and the digastric muscle. Then, left and right lateral division. It is the act of grinding and chewing. The muscles involved are posterior fibers of temporalis, digastric, mylohyoid, geniohyoid, and lateral and medial pterygoid muscles. In this diagram, you can see how the protrusion does. The mandible, it is moving forward. And in the retrusion, or we can say retraction, the mandible comes inside in this movement. So these are the protrusion and the retraction. Now we have the inferior compartment which allows rotational movements. These are depression and elevation. Depression, that is a movement of opening of the mouth. The muscles involved are lateral pterygoid, digastric, geniohyoid, and the mylohyoid. Whereas in the elevation, that is a strong movement of closing the mouth. The muscles involved are temporalis, masseter, and medial pterygoid muscle. In this diagram, you can see elevation, which is also known as a flexion, and depression, which is also known as extension. As we all know, flexion is decreasing of angle and extension is increasing of angle. Now moving forward, we will talk about blood supply and innervation. It is mainly supplied by three main arteries: deep auricular artery, that is a branch of maxillary artery; superficial temporal artery, branch of external carotid artery; and also we have the third artery, that is the anterior tympanic artery, which is also a branch of maxillary artery. And the venous drainage, it is done by the superficial temporal vein and the maxillary vein. And for innervation, we have the branches of the mandibular division of trigeminal nerve, that is the fifth cranial nerve, V3 division. And we have auriculotemporal branch and mesenteric and deep temporal nerves.
The next joint is atlanto-occipital joint. It is a paired symmetrical articulation between cervical spine and base of the skull. The principal movement of this joint is flexion and extension. The articular surfaces. The articular surfaces has oval, concave convex surface within the concave facets of C1 fitting into convex surfaces of occipital bone. There is no intervertebral disc and all surfaces are lined with the hyaline cartilage. The C1 inferior articular facets are oval, concave, and located on the lateral mass of C1, and these are slightly angled medially and oblique in anteromedial direction. The occipital condyles are convex, elliptical, and directed anteromedially, located near the foramen magnum. Ligament and capsules. The capsules is loose, thin articular, composed of fibrous tissue and lined with the synovial membrane. The ligaments. There are ligamentum nuchae, alar ligament, apical ligament, lateral atlanto-occipital ligament, and anterior atlanto-occipital ligament and membrane. There are two membranes also, that are posterior atlanto-occipital membrane and tectorial membrane. In all these ligaments and membrane, there are two principal ligaments, that are anterior atlanto-occipital ligament and its membrane, and the second is the posterior atlanto-occipital membrane. Here, in this diagram, you can see the anterior atlanto-occipital ligament, that is a dense band of fibrous tissue spread from anterior border of foramen magnum to the upper border of anterior arc of atlas. And in this diagram, you can see the posterior atlanto-occipital membrane, that is a thin membrane that covers the posterior aspect of joints. It runs from the posterior margin of foramen magnum to the superiorly upper border of posterior arc of atlas inferiorly. Its primary movements are flexion and extension, and limited movements are lateral flexion. Moving forward, the next joint is atlanto-axial joint. It is a complex joint formed between the atlas C1 and axis C2. It is composed of the three synovial joints, that is, one median atlanto-axial joint and the two lateral atlanto-axial joint. The median atlanto-axial joint is formed between dens of axis and osteoligamentous ring of atlas anterior and transverse ligament posterior. That is a type of pivot joint. The second lateral atlanto-axial joint, it is a bilateral joint formed between the lateral masses of atlas and axis, that is a kind of plane joint. The articular surfaces of lateral atlanto-axial joints, as it is formed between inferior articular surface of atlas and superior surface of axis, the surfaces are oval, obliquely angled, and inclined inferiorly. The capsule, it is a loose fibrous lined with the synovial membrane attaching to the lateral articular facets of C1 and C2. Each joint is supported by an accessory atlanto-axial ligament that extend from the deep laminae of tectorial membrane attaching to the posterior aspect of C1 and C2. Here you can see the atlanto-axial ligament here. Then the second articular surfaces of median atlanto-axial joint. It is a kind of pivot type of synovial joint, and its main components are dens of axis, that is a peg-like projection, anterior arcs of atlas, which forms part of osteoligamentous ring, and last the transverse ligament of atlas that completes the ring. The articulations include two parts, the anterior facets of dens and the posterior facets of the dens. The anterior facets of the dens are convex, fits into the concave surface of anterior arc of atlas, and the posterior facets of dens are concave vertically and convex transversely, that fits against the transverse ligament of atlas. The cartilage, it covers with the hyaline cartilage for smooth movement. In the synovial cavity, there are two cavities, one between the dens and the transverse ligament, and the second between dens and the anterior arc of atlas. The capsule, it is thin, loose, especially superiorly, and allow the wide range of motion. The ligament, it composed of cruciform ligament complex that is formed by three ligaments, transverse ligament of atlas, superior longitudinal band, and inferior longitudinal band. The transverse ligament of atlas runs transversely between the lateral masses of atlas C1. The superior longitudinal band attaches from the transverse ligament of atlas to the occipital bone, and the inferior longitudinal band attaches from the transverse ligament of atlas to the posterior part of axis. Here you can see the transverse ligament of atlas, and in this diagram you can see the longitudinal bands of cruciform ligament here. There are also other accessory ligaments that includes first the tectorial membrane. It is a continuation of the posterior longitudinal ligament here that connect the body of the axis to the foramen magnum, and it covers posterior surface of the dens. The second is the alar ligaments. They are paired ligaments running obliquely from dens to the occipital condyles here, running obliquely. And the third, apical ligaments of dens that attach from the dens apex of dens to the anterior margin of foramen magnum. The fourth one are anterior atlanto-axial membrane, that is a continuation of the anterior longitudinal ligament, and it spans from atlas to axis and connects to the occiput. And the last is the posterior atlanto-axial membrane, that is a continuation of ligamentum flavum, and it connects to atlas and axis continuing to the occiput. The movements include principally the axial rotation, limited flexion, extension, and last the lateral flexion. Moving forward to the costovertebral joint. These describe two groups of the synovial plane joints. It connects the proximal end of ribs with their corresponding vertebrae, enclosing the thoracic cage from posterior side. There are two groups of joint, costocorporeal joint and costotransverse joint. The costocorporeal joint is also known as the joints of heads of the ribs, as it is formed between the heads of the ribs with sides of one or two adjacent vertebral bodies. And in the costotransverse joint, it is the articulation of necks and tubercles of the ribs with the transverse process of the corresponding thoracic vertebra. These type of joints provide pump handle or bucket handle movements. The function includes enabling the ribs to lift upward and outward during breathing. So first, costocorporeal joint. The articular surfaces. It connects the concave costal facets of thoracic vertebra and convex articular facets on the heads of the ribs. The vertebrae T1 to T10 have costal demifacets, means it have two costal facets, superior and inferior. The ribs 1st, 11th and 12th are accommodated by single uninterrupted costal facets on the responding thoracic vertebra. Here you can see the facets. The ligaments on the joint capsule. It is enclosed by a fibrous capsule reinforced by three ligaments. The first is capsular, second radiate, and the last intra-articular. The fibrous capsule extends between margin of the costal and vertebral articulating surfaces. The second is the radiate ligament. It spans from the anterior surface of each rib heads to the adjacent vertebral bodies and intervertebral disc. It spans in three directions. The first is superior, the second horizontally, and the last inferiorly. The superiorly connect rib to the vertebra above, horizontally connect rib head with the intervertebral disc, and the last inferiorly to anchor the rib to its respective thoracic vertebra. This applies to the joint between 2nd till 10th. In 1st, 11th, and 12th rib, it connects the respective ribs to the corresponding vertebra and a vertebra above the intra-articular ligaments. It is present in complex corresponding joints only till 2nd to 9th ribs. It spans horizontally from the crest on the head of the rib to the adjacent intervertebral disc. Here in this diagram you can see the radiate ligament, and in this diagram you can see the intra-articular ligament. The second, costotransverse joint. Only upper 10 ribs participate in these joints by articulating with transverse process of their corresponding vertebra. It is a connection between articular facets on tubercle of ribs and the transverse process of its equivalent vertebra. Its articular surfaces on tubercle of ribs 1st till 6 are vertically convex, while corresponding costal facets on transverse processes are concave. In ribs 7 to 10, the surfaces are flat, oriented infero-medially and posteriorly facing superior surface of the transverse processes. Ligaments and joint capsule. The capsule is enclosed with the respective fibrous capsules that attach to the margins of the articular facets. The inner surface of each capsule is lined with the synovial membrane. There are four ligaments. The first is the costotransverse ligament that fills the narrow interval between the vertebral transverse process and rib neck. Here, it is filling the interval between the vertebral transverse process and the neck of the rib. The second ligament is the superior costotransverse ligament that is present between the superior surface of the rib neck to the inferior surface of the transverse process of vertebra immediately above. It is composed of two layers, the anterior and posterior, which is separated by fibers of external intercostal muscles. Here. The third is the lateral costotransverse ligament that connects the tip of the transverse process with lateral, non-articular, and part of the rib tubercle. Here, at the last points. And the fourth, accessory ligament, it sits medially to the superior costotransverse ligament, separate from it by posterior ramus of thoracic spinal nerve. The primary movements, as it provides a range of motion in small and falls down to the slightly gliding and rotational movements of the vertebral ends of the ribs. The main movements are pump handle and bucket handle movements.
Now we will talk about the intervertebral joints. So the intervertebral joints, they connect directly the adjacent vertebra of the vertebral column. So each intervertebral joint is a complex of three separate joints. So the three separate joints are, one is the intervertebral disc joint and two are the zygapophyseal joints. So this is the diagram showing the intervertebral joints. Here is the joint formation. Next, moving on, again I said there are two types, the intervertebral disc joint and the zygapophyseal joint. So intervertebral is cartilaginous, and whereas the zygapophyseal is the synovial type. If we talk about the articular surfaces, intervertebral, the articular surface are on the vertebral bodies, but in the case of the zygapophyseal joint, articular surface on the articular process. Ligaments will talk for later. If we talk about the movements, so flexion, extension, lateral flexion or axial rotation of the vertebral column, these type of joints perform. Now we will talk separately about both the joints. So first is the intervertebral joints or in the intervertebral symphysis. So about the articular surface, intervertebral disc joints extend from cervical to sacrum 1 vertebral level, and there are no intervertebral disc at cervical 1 or cervical 2 vertebral level. So here's a diagram showing the intervertebral symphysis. This is for cervical to cervical 4 area. This is showing the thoracic 1 to thoracic 3, and this is showing thoracic 12 to lumbar 4 region. Now, in the vertical plane, the shape of the joint surface ranges from flat to cellar. Mainly, the concave shape is formed with elevated margins where they form the uncovertebral joints. This was about the vertical plane. Vertical plane, it's a concave shaped. Whereas in the horizontal plane, the articular surface appear convex anteriorly and concave posteriorly, and this facilitated the formation of the vertebral foramen through which spinal cord passes. Again, to remember, in vertical plane, the shape is flat to cellar concave, and in horizontal plane, it is convex anteriorly and concave posteriorly. Now, the vertebral end plates, they overlie the distal surface of the vertebral bodies and consist of both the bone and the hiatal cartilage in the early life. And the articular surface of the directly adjacent vertebral bodies are separated by fibrocartilaginous invertebral disc. The articular surfaces of the direct adjacent vertebra, they are separated by fibrocartilaginous invertebral disc. Now, each intervertebral disc is composed of nucleus pulposus and an annulus fibrosus. Again, each intervertebral disc is composed of nucleus pulposus and annulus fibrosus. Now, what is nucleus pulposus? Nucleus pulposus, it forms the inner core of intervertebral disc, and it is soft, gelatinous, and highly movable. And the annulus fibrosus, the peripheral, it surrounds the nucleus pulposus. Now, the joints, the ligament and the joint capsule. So the stability of the intervertebral disc is provided by anterior and posterior longitudinal ligaments. So there are two type of ligaments in case of intervertebral disc joints: anterior and posterior longitudinal ligament. This is the anterior one, this is the anterior one, and here is the posterior one. So the anterior longitudinal ligament, it extends from base of the occipital bone to the pelvic surface of upper sacrum. What is the role? Role is to enforce the vertebral column anteriorly. If we talk about the posterior longitudinal ligament, it extends from second cervical vertebra until the first sacral vertebra. Role is to reinforce the vertebral column posteriorly. So this was all about intervertebral symphysis or intervertebral joints. Now, I said you there are two types. Second one is zygapophyseal joint. Now, the articular surface. The zygapophyseal, or we can say the facet joint, is an articulation between superior and inferior articular process of the adjacent vertebral bodies. It is a synovial joint. Joint surface are lined with hyaline cartilage. Now, the articular surface of the cervical articular process are flat and ovoid in shape. In case of thoracic articular process, they are thin and almost flat. In zygapophyseal joint, it is surrounded by a thin and loose fibrous joint capsule. Now, the lumbar zygapophyseal joint, they are distinct as compared to the others. Their anterior portion of the joint have been entirely replaced by ligament flava. Okay. Now, in addition, they contain intra-articular subscapular fat and menisci. Now, the zygapophyseal joints are stabilized by four types of ligaments: the ligament flava, interspinous ligament, supraspinous ligament, and intratransverse ligament. There are four types of ligaments which support or stabilize the zygapophyseal joint. So first, for the ligament flava, it connects the lamina of neighboring vertebral arches. It connects the lamina of the neighboring vertebral arches. Second is the interspinous ligament. It interconnects the spinous process of the adjacent vertebra. You can see here that it is connected to the spinous process of adjacent vertebra. Third is the supraspinous ligament. It joins the tip of neighboring spinous process. As you can see, it is joining the tips of both the spinous process. Now, fourth one is the intertransverse ligament. It extends between transverse process of contiguous vertebra. You can see it is joining the transverse process of the vertebrae.
So now let's talk about sternocostal joints. So they are also known as chondrosternal joints, and they are synovial plane joints that attach the sternum with costal cartilage of the thorax. The first sternocondral joint is an exception, being considered as a primary cartilaginous joint. Keep it in mind. 7 pairs of sternocondral joints. First sternocondral joint attaches manubrium of sternum. This is the first. Next 5 connects mainly to the body, and 7th sternocondral joint attaches xiphoid process. Now, main functions of sternocondral joint is to facilitate mechanical ventilation by allowing the costal cartilage to glide with ribs during breathing. So now types are costochondral joint 1, primary cartilaginous joint, which is also known as synchondrosis. Sternocondral joint 2 to 7 is synovial planar joints, non-axial as well as uniplanar. Articular surfaces include sternal ends of costal cartilage of the true ribs, costal notches on the sternum. Ligaments include radiate sternochondral, ziphichondral, intra-articular sternochondral ligaments. Innervations are intercostal nerve as well as blood supply includes internal thoracic artery. And movements now, it is also said that sternochondral joint first, almost no movement as it is fixed, and sternochondral joint 2 to 7s are translations, mainly super inferiority. Now, let's talk about articular surfaces. We will tell sternochondral joints as SCJ. SCJ is articulations between two articular surfaces, costal notches located along lateral border of sternum, and corresponding sternal ends of first 7 costal cartilages. Sternal costal notch is shallow, concave depression present anteriorly, and in sagittal plane we see surface area of superior costal notches is always greater than the surface area of inferior ones. Now, shape of superior costal notch is ellipsoid, or we can say round shape, as well as inferior costal notch shape is rectangular and irregular quadrilaterals. Now, the seventh costal notch is deepest out of all, with its articular surface forming an acute angle. So, in the diagram, you can see this is an sternum in which it is the jugular notch, this is the clavicular notch, this is sternal angle, or we can also say that manubrious sternal joint. This part is known as manubrium, and this is the body of sternum, as well as this is the xiphoid process forming a joint with sternum's body known as xiphisternal joint. The second SCJ is distinct compared to rest. Sternal articulation is a demifacet rather than one continuous articular facet. This is due to manubriosternal joint of sternum. Superior articular surfaces on manubrium of sternum is beveled in frontal plane, pointing inferior-laterally. Seventh sternocostal joint is also a demifacet due to presence of xiphisternal joint. Second and seventh sternocostal joints are demifacets. Now let's talk about the joint capsule. Second to seventh sternocostal joints are synovial joints surrounded by thin fibrous capsules. The fibrous capsule is marked by synovial membrane which secretes viscous synovial fluids that acts as an lubricant. The articular surface of all SCJs are lined by fibrocartilage. In contrast to its neighbor, the first SCJ is classified as primary cartilaginous joint, that is symphysis, rather than synovial joint. It's an important thing. Now let's talk about the ligament. So the thin fibrous capsule of SCJ is supported by mainly 3 ligaments. First is radiate sternocondral ligament, second is xiphicondral ligament, third one is intra-articular sternocondral ligaments. Now let's talk about another joint, that is sternoclavicular joint. It is a synovial saddle joint that connects the sternum with clavicles. Only direct connection between appendicular skeleton of upper limb and axial skeleton of the trunk. Now let's talk about its type. So it is synovial saddle joint, basically multi-axial. About its articular surface, it is sternal end of clavicle attaches with the clavicular notch of sternum, superior surface of first costal cartilage, intra-articular fibrous cartilaginous disc. The ligaments we'll discuss later. In the innervations, it is medial supraclavian nerve, nerve to subclavius, while blood supplies is suprascapular artery as well as internal thoracic artery. Movement are of 3 types: elevation, protection, and axial rotation, in which elevation is depressions used and protection is for retractions. Now about the articular surface. So this joint is known as sternoclavicular joint. Sternal end of clavicle, the clavicular notch of the manubrium of sternum, and superior surface of the first costal cartilage. Clavicular joint surface is convex and sternal joint surface is concave. So this is the sternal joint surface, it is concave, and clavicular joint surface, it is convex. It forms a sellar or saddle joint. So and we can see that size of sternal end of clavicle is always greater in size of clavicular notch of sternum. Joint congruency is enhanced by the presence of fibrocartilaginous intra-articular discs. Now let's talk about the movement. So it is classified as saddle joint due to the shape of its articular surfaces. However, functionally it has the feature of ball and socket joint, bringing a multi-axial joint with the 3 degrees of freedom. The 3 degrees are elevation, protection, and axial rotation. In elevation we see there is kind of depression which is 40 degree. In protection we see retractions at 35 degrees, while in axial rotation it is 20 to 40 degrees. Now the other joint is manubriosternal joint, which is a secondary cartilaginous joint between 2 parts of the sternum, the manubrium and the body of sternum. So this is the manubrium and this is the body of sternum. So the joint present in between is known as manubriosternal joint, and it forms a manubriosternal angle, or famously known as angle of Louis. Next is xiphisternal joint. The xiphisternal joint is the anatomical junction between the xiphoid process and the body of the sternum. It is a synchondrosis type of joint formed by hyaline cartilage. What are synchondrosis? Joint that are formed by hyaline cartilage, but as we grow old, it ossifies with time and become a synostosis joint. So this is the body of sternum, and this is xiphoid process. So the angle formed between, so the joint formed between body of sternum as well as xiphoid process is known as xiphisternal joint. Thank you.